Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Cannabis in Older Adults, and our presenter is Dr. Grace Hennessy, Associate Chief of Addiction Psychiatry. Dr. Hennessy will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of New York State's substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Hennessy.
Thank you, Dean, for the introduction. Good day, everyone. As mentioned before, our topic for today is cannabis and older adults. I don't have any financial disclosures related to this talk, but I do have a disclosure about some of the content. I have previously recorded a Learning Thursday called The Science of Cannabis, and some of the slides that will be the introductory part of this discussion before we discuss issues with older adults are repeats from that other talk. So they may seem familiar. There are a few new things, but just wanted to make you aware that some of this has been recorded before. So first, let's start with a general discussion of cannabis. So cannabis is the genus of the flowering plants in the Cannabaceae family. There's two main species, Cannabis sativa and Cannabis indica. And a lot of the cannabis that is out in the world today is really a hybrid of these two strains. The plant synthesizes more than 500 compounds, and about 120 of them are phytocannabinoids that have been identified. Delta 9 tetrahydrocannabinol, or Delta 9 THC, or just plain THC, as we'll say in this talk, is the major psychoactive component of cannabis. One of the other major phytocannabinoids is cannabidiol, also goes by CBD. It is the non-intoxicating component of the cannabis plant, but it has other properties, and we'll talk about that later. Cannabis strains are often described by their THC to CBD ratio. And you can see over time that this THC to CBD ratio in the cannabis plant has really changed. This is information that the federal government puts out, and what this represents is the marijuana, the THC, and CBD content in cannabis samples that have been seized by the DEA from 1995 to 2019. So the percent of THC is represented on the left-hand side. The percent of CBD is represented on the right-hand side. And you can see over time, if you start at the bottom, the red line is the percentage of THC in cannabis that it's been slowly but surely increasing over time. And in 2019, the percentage of THC in the cannabis that was seized, these were illegally grown cannabis plants, was about 14.35%, whereas it had started at about 4% in 1995. So quite a big change. Similarly, the CBD content, which used to be reasonable amounts, has declined over time, increased in the early 2000s, but as you can see, it's been on a decline and was about 0.24% in 2019. So again, major changes in the THC content that is in the cannabis plants that are being grown today. It has a lot of pejorative connotations associated with it. It still does get used, and it has a specific definition, which is the dried flowering tops and leaves of the cannabis plants. And the cannabis concentration determines the potency of marijuana. So the flowers have the most potency in marijuana, followed by the upper leaves, the lower leaves, the stems, and then the seeds of the plant, the seeds having the lowest THC concentration of all. CBD is also present in marijuana, but it tends to be present in lower concentrations. Hemp is a low THC variety of the cannabis sativa plant. So it's a very particularly grown strain. And by definition, hemp must be less than 0.3% THC on a dry weight basis. And it has a much higher cannabidiol content. So hemp is usually grown and harvested for its fibers and seeds and flowers. And they're used to make a variety of CBD containing products, such as cosmetics, textiles, and fabrics. Hemp oil is made from the seeds of the cannabis sativa plant. And as I just mentioned, that the seeds were actually very low THC content in the plant, but it is high in CBD. So there is little to no phytocannabinoids in the cannabis sativa seeds, but it's rich in omega-6, and omega-3 fatty acids, and it has many antioxidants as well, and it's used as a supplement. Cannabis concentrates, this is a broad term referring to all products that have been extracted from the cannabis plant. It has the highest concentrations of cannabinoids. Hemp concentrates tend to have higher CBD concentrations. Marijuana concentrates tend to have higher THC concentrations. Some people call these extracts. Concentrates are called extracts. Extracts are called concentrates. Some people make a distinction between the two. It's not terribly important what the distinction is, but just realize that concentrates and extracts are pretty much the same thing. Hashish or hash is the dried resin of cannabis sativa flowers. These are mechanically compressed out of the plant, or they're removed by ice water extraction. Chemical solvents are also used to extract compounds from the plant. Ethanol, carbon dioxide, propane, butane, and other compounds are used to extract the THC and the CBD. And when these chemical solvents are used and these very high concentration cannabinoid extracts or concentrates are made, they're actually called dabs. And the important thing to know about dabs, if you hear that term, is they can be up to 90% cannabinoid, so either THC or CBD. So incredibly, incredibly high concentrations of these compounds in the dabs. Here is a picture that just shows you the different types of concentrates and what they look like. So distillate oil, which is in the upper left-hand corner, is actually what ends up in being used in a lot of cooking products. So cannabis-infused oils or other baking goods. And these other these other types of concentrates are represented here are just different names and types you may see. So they have interesting names like shatter because it looks like shattered glass, wax because it kind of looks like earwax, crumble looks like cookie crumble, sand, sauce, sugar, butter, budder, but it kind of looks like butter, butter. And there are others, but just wanted to give you an idea of what some of these concentrates look like. And again, these have very, very high THC or CBD content. And in this case, these are all THC dabs. There are also FDA-approved cannabinoid medications. Here's a table that just reviews them. On the top, there's cannabidiol, which has a brand name called Epidiolex, which is actually just pure CBD. It's a solution that is used for the treatment of Lennox-Gastaut and Dravet syndrome. These are two very, very severe seizure disorders that occur in children. They're so severe that children have difficulty with their development and their learning. They can have several hundred seizures a day, but the CBD actually helps decrease the number of seizures that they have per day and lets children develop more normally. Dronabinol is the next one. Dronabinol goes by two names, brand names, Marinol and Syndrose. This is a synthetic or a lab-made THC. It comes in a capsule or a solution, depending on the product. And it has a very particular use for anorexia or loss of appetite associated with weight loss in people who have HIV or AIDS, and nausea-associated chemotherapy. Syndrose, which is the solution form, also is approved for vomiting that goes along with cancer chemotherapy. So they make a distinction there. I'm not sure why, but there is. And the last FDA-approved medication is Nabilone, which goes by the brand name Sesamet. This is a synthetic cannabinoid that is similar to THC. It comes in a capsule, and its only indication, FDA indication, is nausea associated with cancer chemotherapy. So just to make the point that there are medications that mimic THC or CBD as well. There are also the other synthetic or man-made cannabinoids, or the SCs. These go by names like synthetic marijuana, K2, spice, and many others. These mimic the effects of THC, but they are way more potent than the THC that comes from plants. They're sprayed or coated on plant materials that are then smoked. The packages are usually labeled with not for human consumption to avoid any kind of legal consequences. And the synthetic cannabinoids are also mixed into liquid, vaped in electronic nicotine delivery devices. They're added to herbal tea or food and consumed, and they may be mixed in and sold as other substances. You can get them on the internet, small local stores, gas stations, and there's false advertising that synthetic cannabinoids are safe and natural. They're not. Again, these are lab made. They are not safe, and they can be quite dangerous for people when they use them. There are hundreds of different types of synthetic cannabinoids. Two packages from the same manufacturer can have different types of synthetic cannabinoids in variable amounts. We don't know a lot about the long-term effects of synthetic cannabinoids like spice and K2 and synthetic marijuana. More is known about their acute effects. There's scarce data on the abuse liability or the addictive properties of synthetic cannabinoids. Anecdotally, providers will tell us they see people that they treat in their substance use disorder treatment facilities who have a challenge stopping using synthetic cannabinoids. But again, we just don't have a lot of good data about it. The other thing about them is they are not detected in the urine by standard urine drug screening tests. So they're very hard to detect. And if someone's using them, you may not be able to test to prove that someone might be using them. Okay, so let's talk about how the cannabinoids affect us internally. So all cannabinoids are similar to neurotransmitters called endocannabinoids. There are two that our body makes. There's N-arachidonyl ethylenolamine, or AEA, which also goes by the more generic name anandamide, which is the Sanskrit word for bliss. And there's also 2-arachidonyl glycerol, or 2-AG. So again, our bodies make these. We have natural cannabinoids in our bodies, the endocannabinoids. And so both endocannabinoids and cannabinoids that come from the plant or from the synthetic cannabinoids bind to cannabinoid receptors, which have the very simple names CB1 and CB2. CB1 receptors are found primarily in the brain, while CB2 receptors are found in the immune system, gastrointestinal system, and the peripheral nervous system. CB1 receptors are found in brain areas that are involved in a lot of our functioning. So first is motor control and planning, which is an area of the brain called the basal ganglion, coordination, which is in the cerebellum, memory and learning, which are located in the brain in the hippocampus, reward processing, which is in the ventral striatum, judgment, which is in our prefrontal and frontal cortex, emotional processing in the amygdala, appetite in the hypothalamus, and gastric motility, which is in our brain stems. You can see there's a lot of CB1 receptors throughout the brain, and has a lot of effects on our functioning. CB2 receptors are mostly found outside the brain. They're in the immune system organs and cells like lymphocytes and leukocytes. Generally, we call those white blood cells. So our white blood cells have these receptors. The spleen, tonsil, and thymus, which are all major organs in your body that are involved in immune functioning. And receptor activation of these CB1 receptors causes immune suppression. So you get inhibition of the movement or the migration of immune cells. It also inhibits the production and release of pro-inflammatory cytokines. And enhances the production of anti-inflammatory cytokines. So what really all that kind of jumble of words means that you get reduced inflammation and inflammation-induced pain when CB2 receptors are activated. This is particularly true in the gastrointestinal system and in our joints. And it also may affect the pain related to nerve damage by reducing inflammation, which is called neuropathic pain. It also may decrease the immune response in autoimmune disorders. So let's go back to THC and talk about how its pharmacology. So THC is most rapidly induced into the body by smoking, vaping, or dabbing. So when you smoke, vape, or dab, you bring it right into your lungs. It goes up into your blood and straight up to your brain. THC is actually what we call a partial agonist at the CB1 receptor, so it doesn't fully turn it on. It sort of gets in there. It's like a dimmer switch in your room. So if you have the type of room where you have a light where you can turn it all the way off or all the way on or somewhere in the middle. So THC is sort of like turning the dimmer switch to the middle. So it activates the receptor, but again, it doesn't fully activate it. It's not like having the light fully on in your room. Psychoactive effects related to THC after you smoke or vape or dab occur within minutes, and they last a few hours. Oral ingesting makes things go a little bit slower. So if you eat something through food products, it has to go through your stomach, your blood, then your liver, then back into your blood and up to your brain. Your stomach acid and your liver will break down some of the THC, so you're not getting as much as you would if you were smoking. It may take an hour or more to feel the psychoactive effects because of this. The effects will also last longer, but it's also of a lower intensity. THC is converted to 11-nor-9-carboxy-THC or THC-COOH, which is what's in the parentheses, and that's the primary urinary marker of cannabis use. THC accumulates in fatty tissues, which we term that lipophilic, which just means it likes to be in the fatty tissues. And then it's slowly released back into the bloodstream. So that means the detection time of THC in the urine is variable. And it also is affected by the amount of THC that you use and the potency. So what was that percentage of THC in the product that you use? Are you a regular user or an occasional user? Depends on the rate of THC released back into the bloodstream. And the range can be from 3 days for a single use up to a month or more for chronic use. A positive test, always remember, a positive urine test for THC only identifies past use. It does not correlate with impairment. It just means that you've used and within a period of time, and you can stay positive for quite some time, depending again how frequently you use, how much you use, and the potency of the cannabis that you're using. Dronabinol, which is one of the medications that we mentioned earlier, that is for nausea associated with chemotherapy and also for weight loss and loss of appetite associated with HIV, will cause a THC positive urine test. So if someone is taking that, they will come up positive, but you don't get a positive urine test with Nabilone or Epidiolex, which is just CBD. As I mentioned before, the other synthetic cannabinoids, K2 spice, synthetic marijuana, they will not come up positive unless they're mixed in with marijuana or cannabis that is eaten or smoked. CBD products without THC should not test positive. Speaking of CBD, in terms of its pharmacology, it comes in capsules, edibles, oils, or liquids that can be sprayed in the mouth or placed under the tongue. It can also be smoked, vaped, or dabbed. There's topical creams, ointments, lotions, and actually even bath bombs. Smoking, vaping, and dabbing, just like with THC, will result in the most immediate effects because that, again, avoids that initial liver breakdown from the edible products. And the presence of food does actually increase absorption of orally consumed CBD products. So a high-fat meal can actually quadruple the amount of CBD in the blood. The effects of CBD are felt in about an hour when ingested and last up for about 3 hours. And the edibles are broken down by stomach acid and liver. Challenge with CBD products is there can be variability in them. This was a study published in 2022 by Spindle and his colleagues, and this was a study looking at the cannabinoid content and label accuracy of hemp-derived topical products available online and at national retail stores. So what they did is they got 105 hemp-derived topical cannabinoid products, and they analyzed them for accuracy and CBD and THC labeling. The retailers that they got the products from were grocery stores, pharmacies, cosmetics, beauty, wellness, health stores. So really anywhere that most people shop, you could get these CBD products. They also went online and they identified the products by Google using relevant keywords, including hemp and CBD topical, hemp, CBD transdermal, full spectrum hemp, and CBD topicals. And what they got out of the products were mostly balms, creams, salves, and patches. So things that you put on your skin. What they found, though, was that the products were not always so well labeled. So remember, there were 105 products, and they found that 89 or 85% listed the total amount of CBD. So, that's okay. But again, 15% did not have the total amount of CBD. So people did not know what they were getting. But when they broke it down into what was on the label and what was actually there, they found that 16 of these products, or 18%, were actually over-labeled. So they said that they contained more CBD than they actually did. 52 or 58% were actually under-labeled, so they contained less CBD than they actually did. And only 24 of the products were accurately labeled, or 21%. So there was some definite variability in the amount of CBD in these products, even when they said they actually contained it. Interestingly, THC was detected in 37 out of the 105 products, or 35%. All of these products contain less than 0.3% THC. So they were incredibly, incredibly low, and they were at the level that is expected when the level of THC expected in a hemp-derived product. 4, though, of the products were labeled as THC-free when they were not. 19 or 51% of the products did not reference THC on the label whatsoever. And 14 or 38% of the products were labeled as having less than 0.3% THC, which would have been accurate. So again, there's a lot of concern about some of this variability. CBD products right now are not monitored by the FDA. They don't have to be. So there's some concern about, what you're getting may not be exactly what you are getting. In terms of the THC in the products, it is a very low amount, and it should not be significantly absorbed by the skin. So there's sort of no concern that there would be, you would become intoxicated from the THC. But again, it just sort of goes to the point that there's not full disclosure in the labeling, and it can be inaccurate. CBD pharmacology, it's converted by the liver to 7-hydroxy-CBD and 7-carboxy-CBD. CBD was found to elevate liver function tests in some children with the seizure disorders who were taking the medications, but there was no serious liver damage in the Epidiolex trials. And it was more likely to happen when they were taking other anti-epileptics or anti-seizure medications that also had effects on the liver. CBD does affect liver enzymes that break down certain medications, which may increase or decrease blood levels of other medications. Epidiolex increased blood levels of a benzodiazepine called clobazam, which is not really commonly used in the general population, and it's only approved to treat Lennox-Gastaut syndrome, which is one of the serious seizure disorders that we mentioned earlier. They found in these children they had increased sedation when they took both medications, but that the sedation got better when they stopped one or the other. This is not well studied yet in humans. There is some concern, but we don't know yet. So it is, again, a concern that CBD may have interactions with other medications, but more information is certainly needed. So what are the acute effects of cannabis? So people feel high or euphoric, they have impaired attention and short-term memory issues, impaired judgment, impaired motor coordination, slowed reaction times, distorted sensory perceptions, conjunctival injection or red eyes, increased appetite, dry mouth, elevated heart rate, and it quells nausea and vomiting, or it's an antiemetic. Less common effects, usually at higher THC doses, are anxiety, fear, panic, and paranoia, nausea and vomiting, dizziness, and hallucinations, which are incredibly rare, but people do have had them at higher doses. And the magnitude of any acute signs or symptoms depends on the amount and potency of the cannabis smoked or consumed, the route of administration. So smoking or dabbing would be much likely to get higher amounts of THC and perhaps these negative acute effects than, say, eating products, the route of administration, and individual characteristics such as a naive versus a regular user. Cannabis overdose, I put overdose in quotes because there's no reports of anybody dying directly from the effects of cannabis, say in the way they might from an overdose of opioids. So it's sort of in quotes there, but people can have very severe reactions that feel very unpleasant. Again, it's not fatal, but people experience anxiety, confusion, tachycardia, or a rapid heart rate, which can lead to chest pain, and people also experience an elevated blood pressure. It's usually due to excess consumption, particularly of edible products, because the lag time, again, between consuming an edible, as we mentioned earlier, and feeling its effects can be a couple of hours. So sometimes people will ingest extra amounts, so people will eat more and more, hoping to get high sooner, and then it kind of all catches up with them a few hours later. The other challenge can be the inaccurate product labeling. Inconsistent manufacturing standards of cannabis products may also contribute to this as well. Going back to the synthetic cannabinoids, so again, these are the fake ones. So the fake marijuana, the synthetic marijuana, so K2, spice, these mimic the effects of THC. So people do feel high, they get that distorted sensory perception and all the other things that were mentioned on the other slides, but the effects are more pronounced. As I mentioned earlier, THC is a partial agonist at CB1 receptors. So it's that dimmer switch that kind of goes halfway. So it doesn't light up your whole room, but you get a good bit of light. But the synthetic cannabinoids found in spice and K2 are full CB1 receptor agonists. So they just take that dimmer switch and they just turn on the lights 100%. And that's what makes them more potent than THC. So you're getting a lot of THC effect from them. And they also have a higher affinity for the CB1 receptor. So they really like to, and they're drawn to that CB1 receptor. So they'll bind in there tightly, and that also enhances the effects. There's also no CBD in synthetic cannabinoids, and the CBD seems to have some countering of the intensity of THC effects in cannabis. So without the CBD in the synthetic cannabinoids, you're getting, again, probably some more intense THC effects than you would when you're using cannabis. The acute effects of synthetic cannabinoids can be a bit more severe. You can have reactions that cause agitation, anxiety. People get psychotic symptoms, so they may hear voices or see things. Very elevated heart rates, elevated blood pressure, nausea and vomiting. People can have seizures. You can get kidney damage, and people have even died from synthetic cannabinoids. So it's a very much more serious and significant effect that can be quite dangerous for people. What about addiction? So THC is involved in the development of addiction. THC increases dopamine release in animals and humans, and this is a key neurobiological process in the development of addiction. This is associated with the positive reinforcement of the rewarding effects. If you remember earlier when we were talking about the CB1 receptors and where they're located, they are located in areas of the brain that manage reward. THC then gets afforded what we call an exaggerated salience by the brain. And salience is a word that just is a stimulus or an aspect of a stimulus that stands out. So THC suddenly becomes this thing that your brain goes, wow, that thing is good. We like that. It stands out. So the brain will really react to it then. And as you continue to use THC, so chronic THC administration over time will decrease the number of CB1 receptors in the brain, and it decreases in dopamine. DA means dopamine release in the reward center. So the brain kind of reacts by pulling back a bit on the THC receptors and how much dopamine gets released. But then what your brain says is, well, you need to take more and more because we want to get these effects again. And that's how you end up with tolerance. So again, you increase your use in an attempt to achieve the same effect, but it's not happening because the brain is making these changes. Okay, so now that we've had this kind of general discussion about cannabis and THC and CBD, kind of to help lay the groundwork and remind you of some issues related to cannabis and cannabis products, I want to shift to a discussion about older adults. So one of the challenges is that we don't know as much about cannabis use in older adults and the effects in older adults as we do for younger and middle-aged adults. The reasons for this include limited research on cannabis in general, because it is a Schedule 1 substance by the DEA. So Schedule 1, when you talk about Schedule 1 substances, those are medications or substances that are found to have no medical use and are highly addictive. So if it's in that schedule, the government has a hard time really letting scientists study them. So that's part of the issue. So it's not just about older people, it's about everybody, but there's that limited research on it. So the second problem is it's limited in general, but it's even limited that much more in older adults. And the research is what we call cross-sectional studies. So cross-sectional studies look at something that's happening sort of at like one discrete period of time. They're very useful studies, but it only gives you sort of a snapshot of things that are going on and not more of a longer picture. So say like, you know, having a group of older adults and following them for 5 years and seeing what the effects are when they use cannabis over a long period of time. We don't have as many studies looking at that. Finally, there's this real lack of a uniform definition of what an older adult is in research studies. So the Center for Disease Control defines older adults as 65 years and older. They do a lot of research and fund a lot of research, but the World Health Organization actually defines older adults as 60 and older. So many really a lot of the research studies use the CDC definition, but some studies actually define the lower end of the range of older adults in the 50s or the mid 40s even. So that kind of muddies the water a little bit because a 50-year-old is not the same as a 75-year-old physiologically, psychologically. So that's one of the challenges that comes up in the studies. So with this in mind, I tried to focus on more general information about older adults and what we're seeing regarding cannabis use. So the first thing that we see among older adults is a decreased perceived risk associated with regular cannabis use among older adults. This was a study that was done published in 2021, and it looked at older adults in the United States. They looked at about 19,000 of them, so a large sample from a survey, the National Survey on Drug Use and Health, and they looked over a 4-year period. And they focused on a particular question. So how much do people risk harming themselves physically and in other ways when they smoke cannabis once or twice a week? And the responses that people could give were no risk, slight risk, moderate risk, and great risk. And for this study, they focused on the number of people who said great risk. So this is a graph that shows you what they found in this study. So on the left-hand side is a perceived risk of regular cannabis use and a bunch of percentages and what has changed over the years. So this is a trend in the people saying that it represented a great risk. So you can see over about a 4-year period, it decreased from an estimated 53% up here in 2015 down to about 47% in 2019. So there's definitely a change in the way that older people are viewing cannabis. And part of the reason may be is that we have to think about the cohort who now make up the group of older adults. So if in 2019, if you go back 50 years, which was about 1969, and that was really a lot of the heyday of a lot of the substance use that was going on, Woodstock, lots of kids experimenting with substances. Now in 2019, let's say you were 18 years old, you're now 68. So you may, as someone who had used substances or had some exposure to substances, particularly marijuana, may have a different view of it because of your younger experiences. The study did not really look at all the reasons why. People think that's probably a reason why. It's sort of the aging of the group and what their experiences were with cannabis in the past. So that may be a contributing reason, but there's probably more, and we don't necessarily have all of them at this time. So this change in the perception of harmfulness may be reflected also in the increased use of cannabis among older adults for similar reasons. So this was a study from 2020 looking at trends in cannabis use among older adults in the United States from 2015 to 2018. And this was an analysis of approximately 15,000 adults, 65 and older, from the most recent 4 cohorts of the National Survey on Drug Use and Health. So that study I mentioned in the last slides. And they estimated the prevalence of past year cannabis use, so within the past 12 months. And they had a broad definition of cannabis. When they asked the participants, it meant marijuana, hashish, pot, grass, hash oil. And they asked the respondents if they smoked or ingested the cannabis products. What they found was that the past year prevalence of cannabis use among older adults in the United States actually increased These were not huge increases, so you can see the past year cannabis use percentages, 1, 2, so it's up to 6%, and then the change over time. So it's not tremendously large numbers, but there's definitely an increase in the number of individuals doing that, so who used in the past year. So the increase was from 2.4% to 4.2%, which was about a relative increase of 75%. And so there's some increase in numbers there. The shading is just the confidence interval. It's just a sort of it shows you that the range of percentages is somewhere between the top and the bottom of the gray lines. Another study looking at the trends among older cannabis users in the United States came out in 2017, and this was an analysis of 47,000 adults 50 and older from, again, the same sort of study group that they were looking at, and this estimated the prevalence of past year marijuana use. So the prevalence estimates for self-reported past year cannabis use, they looked at socio-demographic, chronic disease, and substance use characteristics for adults 50 years and older between 2006 and 2013. And what they showed, again, was that there was about a 2% increase overall, an absolute increase from 2.8% of older adults to 4.8% between 2006, 2007, and 2012, 2013. When you sort of look at it as a relative change, comparing the 4.8 to the 2.8, it's actually about 70%, 72% increase in the number of adults. And interestingly, the biggest increase when they looked at age groups was the 65 and older group. So they went from 0.4% back in 2006, 2007, and they jumped up to 1.4 in 2012, 2013, and that's a relative change of about 250%. So want to stress these are small numbers, but just really kind of shows that there is this growing trend that's going on. The numbers went up for males and females as well, as you can see in this section. And in terms of race and ethnicity, the largest increase was among non-Hispanic white individuals, although there were notable increases for both non-Hispanic Black, Hispanics, and for all other groups. The largest group was sort of all other racial and ethnicity groups, which covers a large group of individuals, and it was not really broken down very well in the report of the study. So this was a study that tried to look at the why. So more older adults are using cannabis. What are the reasons for them doing so? So this was a study called Emerging Treatment for Common Symptoms in Older Adults in 2021. It was an anonymous survey of 586 adults aged 65 years and older, and it assessed their characteristics of cannabis use. This was a survey that was done in a geriatric clinic in San Diego, California, over 8 weeks. And they had 83 survey respondents who reported cannabis use in the past 3 years. And they compared those who had used cannabis in the past 3 years they compared those who had used cannabis within the last 6 months to those who had used cannabis between 3 years and 6 months prior. So they chose the 3-year window because it had been 3 years prior that California had legalized adult use or recreational cannabis use in adults. So they wanted to kind of compare these cohorts with one another to see what was going on and why these adults were using cannabis products. So this just gives you sort of some demographic information. So there was a smaller group who had used between 6 months and 3 years ago. It was about 27, and a much larger group had used within the past 6 months. So when they broke it down by age, the largest groups who were using either in the last 6 months or really even in the past were those between 65 years old and 84 years old. And you can see more had used in the past 6 months than had used in the 6 months to the 3 years prior. And there was a notable number who were 85 and older who were using. Again, not a huge number, but about 9 of the respondents who were using cannabis products in the past 6 months were 85 and older. They were more commonly female, interestingly, in the past 6 months than male, so 31 versus 25. Again, not huge numbers, but it did lean more female. And this was a very predominantly white group. So I do want to stress that this may not be representative of all older adults of different ethnic groups, but there aren't that many studies out there. So I used the ones that they had, but this again, I want to be clear that this was not a very racially diverse group, and that would be an area where we need more study. So this is the characteristics of the group, and then this is some more information about them. Many of them, I'm just going to focus on the past 6 months on this side, were daily users of cannabis products. Monthly was followed by next closely by monthly use. And most of them, although by a very tiny margin, were using CBD only products. So if you look in the column, about 25 of the 56 or 45% were using CBD only products, but 44% or 24 were using products also containing THC. And there was a small group that wasn't sure of what products they were using, but they were probably using, something that contained both. They just weren't sure. The majority of older adults are really using these products, as you can see, in the past 6 months for medicinal purposes only. 80%, 43 people in the sample were using for medicinal purposes only, a smaller group just for recreational, and then an intermediate group, about 17%, were using for both medicinal and recreational purposes. And a lot of them were getting the products at dispensaries. So the sort of like we have in New York State, we have the legal dispensaries. So these are places where people can go and they can learn a lot about the cannabis products from the people who are selling them. And these are usually legally run by the states. Some people were getting them from delivery services and from other folks. But again, want to stress that the main place that people were getting them from was a dispensary. What was the characteristics? How were they using them? The majority of folks were either smoking, you can see 24% within the past 6 months, or edibles were 24%, but a lot of them were actually using different types of products. So you can see lotions down here is 38%, and tinctures, which drops under their tongue, were actually the leading ways that the older adults were using cannabis products. Again, they were smoking and eating, but they were more likely to use products that they were putting on their skin or sort of products they could put under their tongue. Why were they using them? So pain and arthritis were the main reasons that older adults were using these cannabis products. Again, as mentioned earlier, they were saying they were using them mostly for medicinal reasons. This sort of shows all of this. Sleep was a somewhat distant but an important second at 24%. 20% were using for anxiety, 14% for depression, and then there's sort of the numbers kind of drop off notably from there. The other category was the next largest number at 8%. And then you have people taking them for dementia, libido, so for their sex drive, migraines, vomiting, glaucoma, and appetite. The other findings for this study is that 75% of the sample who was using cannabis products, so again, it was only about 83 people, but a majority of them found cannabis somewhat or extremely helpful for their symptoms. 61% of respondents used for the first time as an older adult. So most of them had never used any cannabis products before the age of 65. And when they compared those who had used in the past and who did not use now to those who used cannabis for the first time as an older adult, that group who had used for the first time as an older adult were more likely to be older. So 50% were in the 75 to 84 year age group. They used only CBD products, so 57%. They used for medicinal purposes only, and they used in other ways other than smoking or vaping, like we just talked about. So 45 are using lotions, 41% tinctures, 14% use pills or edibles, and only 10% smoked or 12% vaped. So again, so people who started as an older adult, 65 and older, really used in very different ways than people who had used when they were younger. Again, leaning more towards CBD products, leaning more towards medicinal use, and not using in ways that that were smoking or vaping. One of the downsides that there is concern about is the potential for poisoning with cannabis products. There was a study in 2021 that looked at cannabis and synthetic cannabinoid poison center control cases among adults age 50 and older from 2009 to 2019. So this study unfortunately brought the age of older adults down a little bit to 50 years old. They said that for if they did 65 and older, they would not have had as many cases. But again, so the water's a little muddied on this one because it is about 50 and older, so not quite the traditional older adult definition. Cannabis-related cases increased almost 18 times during the 11 years. There were 61 cases in 2009 and 1,074 cases in 2019. And the greatest increases were poisonings related to the synthetic cannabinoids. And the odds ratio for major medical outcomes or death were much greater for those who had had a poisoning by synthetic cannabinoids. So that was twice as likely to happen with a synthetic cannabinoid as opposed to other cannabinoids. And here's just a graph that shows you what was going on with these poisoning cases. The synthetic cannabinoids are this blue line. You can see there is this incredible spike between 2014 and 2015 when the most cases were reported. And then it dies off a little bit. It's not as high as some of the other cases over time. But again, the synthetic cannabinoids really, really stand out as being a major source of poisoning among older adults related to cannabis products. The other major lines that go on in here are the dried plants, and there's some information about undried plants. What has increased over time is sort of the edible preparations, which again may be because people are eating more, trying to get the effect. They don't give great reasons for the poisonings. Again, this is one of those studies, as we mentioned, it's cross-sectional. It looks at a period of time and just sort of gives information. Probably, though, this spike in synthetic cannabinoids that sort of happened between 2014 and 2016 occurred because that was a time when there was a lot of synthetic cannabinoids out there. That was sort of the big rise of them being incredibly available in local stores, in bodegas, in other areas, and people were trying them and experimenting with them. So that is really probably why we see this tremendous peak between 2014 and 2015. And then the drop off over time as people had more education about them and they were not as widely available out in the public. Final study is about mental health and cognition in older cannabis users. This was a review from 2020, and this was a review of 16 original research studies on mental health comorbidities reported by older adults in the past years. And again, this was another one where the lower range was set at 50 years old, so they could widen the scope of the findings because the literature on cannabis users age 65 years and older was lacking. This looked at the mental health conditions that people reported. So what they did was they looked at past year users versus never users, and they looked at the prevalence of certain mental health conditions in the past year and also over their lifetime. And you can see from this chart that past year use of cannabis was very much associated with some mental health conditions. The folks reported more in terms of lifetime use. So you can see major depression. Those who had used cannabis in the past year also had past year reports of depression at about 17%. And over their lifetime, they were more likely to have depression as well, with 32% reporting depression. Bipolar, so this was one where they actually had a comparison. So 3.8% of past year users reported past year bipolar disorder, whereas only 1% of never users did. And when you looked at lifetime, it was 4.3 versus 1.5%. In terms of suicidal ideation, people who used in the past year had been more likely to report suicidal ideation at 5% versus 2% for never users. The lifetime was not reported in this study. Also, attempts were not reported. But lifetime users were more likely to, past year users were more likely to report lifetime suicide attempts at 10% versus about 3% for those who never use. Anxiety disorders were much higher again among people who used in the past year, 23% and 30%. There was no never user comparison. PTSD, again, about higher at 9.4% for past year and for lifetime. And substance use disorders were also very common among individuals who had used cannabis in the past year and in lifetime, 65% versus 18%, and then 82% versus 27%. Looking at substance use disorders more carefully, nicotine use disorder was much higher at about 48% compared to never users. Alcohol use disorder, about 29% versus 5%. Cannabis use disorder, 17%, and other drug use disorders of 8.4% versus about 0.8%. So the challenge with this is it definitely shows us something important about mental health and substance use issues among people who have used cannabis and older adults who use cannabis in the past year. But it's hard to know which came first. This study doesn't really get into chicken and egg. This is just sort of a report of what they experienced in the past year. So there's definitely a concern. It's something we should be thinking about, that are people using because they have depression or bipolar disorder? And how can we help older adults who are using, who may need other types of treatment for these co-occurring conditions rather than using cannabis? There's also an issue with side effects that come up with medical cannabis use. So this is a report from a study that looked at most older adults when they use cannabis report somnolence, drowsiness, and sleepiness. That percentage in there is a range from the studies. So in some studies, 3% only reported it. Other ones, 52%, but that was the highest number completely. Confusion, subjective worsening of memory, anxiety, panic attacks, dizziness, paranoia, and psychosis were also reported by the adults in notable numbers. They decreased from top to bottom. But again, somnolence, drowsiness, sleepiness being the most important, and that being a concern because one of the things we do worry about with older adults is falls. Falls are common as people get older. And if you're feeling drowsy or dizzy or sleepy or confused, the likelihood that you can fall goes up. So this is a side effect that we do have. These are side effects that we do need to keep an eye on with older adults who are using cannabis. Lastly, there was a interesting study that I want to finish up with the acute effects of THC being different in aging adults. This was a study of 86 adults between the age of 21 and 70 who were regular smokers of high THC content cannabis. There were 54 adults aged 21 to 25 and 32 adults 55 to 70 years. So they all smoked cannabis flower that comprised 3 THC to CBD ratios, so 24% THC and very low content CBD, 23% CBD and very low THC content, and another version that was a similar concentration of THC and CBD at 9% each. And what they did was they did some testing before and after smoking from this group. So again, they were all regular cannabis smokers. But before they smoked these particular ratios of THC and CBD, they did tests on learning, processing speed, executive functioning, and attention. And they also did subjective measures pre and post smoking, like their sense that they were intoxicated, their level of craving, anxiety, and dizziness. They found that the high THC content cannabis had a greater negative effect on younger adults, interestingly, post smoking than older adults. The younger adults performed significantly worse on cognitive tests of learning, processing speed of information after they smoked the cannabis. The older adults did a lot better. There were no significant group differences on attention and executive functioning. So the younger and the older adults did very similar on those types of tests. And they found that the younger adults had significantly higher scores on measurements of cannabis craving. So after they smoked, they wanted cannabis more than compared to the older adults. There were no differences, though, between the older and the younger groups on measures of anxiety, intoxication, or dizziness. There were also no significant differences in any measure between the younger and older adults who smoked high CBD content cannabis and similar THC and CBD cannabis. So the question is, could older adults be less sensitive to the effects of THC? And this is what the authors were wondering because we change as we get older. So they hypothesize that there are age-dependent changes in the endocannabinoid system, that CB1 and CB2 receptor expression declines with age. So what that means is just over time, there's less of those receptors in the brain. So if there's less receptors around, there's less ability for the brain to be affected by the THC that's there. Also, endocannabinoid expression decreases with age. So our own sort of circulating cannabinoids are less. So when THC and CBD were brought in, they may not affect the balance as much because there's not as much internal cannabinoid to begin with. So we're not sure about this yet. This is something that needs more study, but this seemed sort of kind of interesting. Again, this was not what I was expecting when I first read this study, that the younger adults would have done worse in certain ways than the older adults in terms of the effects that they experience from THC on certain cognitive testing. So just want to finish up with some ideas for you about having conversations with older adults about cannabis. So if an older adult wants to talk about using cannabis or cannabis products, you should employ a non-judgmental, person-centered approach. You should listen actively to understand what symptoms the older adult is trying to alleviate. You should engage the older adult in a discussion about the evidence of the risks of using cannabis based on the individual's history and current medical issues and medications. Alternative treatments to cannabis and cannabis products for their symptoms should be discussed. And if it's something maybe they need a referral for, like we mentioned earlier, there were the studies where people had reported depression in the past year. The past year users had a higher percentage than non-users of depression. So maybe they need to see someone to talk about the issues that are causing depression, or maybe they need medications for it rather than cannabis. If they are going to smoke, provide harm reduction strategies. So talk to them about using cannabis or cannabis products only when nothing important needs to be accomplished, like work obligations. Encourage them strongly to avoid non-prescription synthetic cannabinoids, as we saw the serious issues with poisoning and medical complications related to older adults who had used synthetic cannabinoids in the one study. Avoid using over-the-counter CBD only products, or use with extreme caution because they are poorly regulated. And use higher CBD, lower THC cannabis strains and products, because as we saw, those did not affect people as much in the study that we just reviewed, where older and younger adults were compared. Again, more harm reduction strategies: do not use cannabis products, and operate a motor vehicle or heavy machinery. Do not mix cannabis products with other substances, particularly sedating ones, and safely store cannabis products in a locked box or other locked container away from children and pets. And that's what we have for today. This is my email in case anybody wants to reach out to me directly with any questions about the talk. And just want to thank everybody for your time and attention today.
I want to thank Dr. Hennessy for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.